Intracerebral hemorrhage. Please, check the description for disclaimer and bibliography.
When an arteriole in the brain itself ruptures, then it starts bleeding into the parenchyma. Some key drivers of the amount of blood leaked is the arterial blood pressure, as well as the state of the coagulation. Two things that slow down and stop the bleed are the formation of a clot on the rupture arteriole or capillary, increase in the regional tissue pressure that will tamponade the bleeding vessel. So it is important to lower the systolic blood pressure to a range of 120 to 160 millimeters of mercury. Correct coagulopathies bring the head of the bed up to about 30 degrees to decrease the pressure head by gravitational counter mechanism. Then cross your fingers that the intralesion pressure tamponade the bleeder soon to stop the bleeding.
When the bleeding stops, then a blob of blood, a hematoma, a bruise, is left behind in the tissue. The hematoma can exert mass effect and compress neighboring tissues. That may include the CSF pathways that may lead to complications such as hydrocephalus. But the hematoma needs to be cleared, and the body will by an inflammatory process that takes time. Of course, the larger the hematoma, the longer it will take to clear, and the longer the recovery. And the higher the likelihood of complications. The healing process, because of the inflammation, can lead it to a variable amount of perihematoma swelling, which itself can lead to more problems.
The causes of non-traumatic bleeding in the brain parenchyma are chronic arterial systemic hypertension and amyloid angiopathy. Other causes of bleeding in the brain include coagulopathies, arteriovenous malformations, cancer, endocarditis, eclampsia, illegal drug use, among others.
Chronic systemic arterial hypertension, by variety of mechanisms, induces stresses on the arterial wall that weakens it, and eventually leading to spontaneous arteriolar rupture. Seemingly, by virtue of their longer length, the long perforated arterioles are more susceptible to the effects of this stress with subsequent risk of rupture.
In amyloid angiopathy, a normal body protein in abnormal 3D configuration, and so becoming toxic to the tissues where it deposits. When this happens in the arterioles and capillaries of the brain, then the weaker vessels are prone to recurrent ruptures, with consequent recurrence of micro and macro hemorrhages. The main long-term management is also control of the blood pressure.
Common locations of hemorrhages are lobar hemorrhages, which occur in the lobes of the brain. In the basal ganglia region and thalamus, these locations are more common in the case of hypertensive etiology. But the hemorrhages can also occur in the brainstem and the cerebellum.
The majority of patients with ICH will probably be admitted to the intensive care unit, or the step-down unit, unless the symptoms of the bleed, and the imaging appearance suggest a small volume of bleed, in which case they may end up on the neuro floor. Patients that have the following characteristics are better, at least initially, managed in the intensive care unit. Symptoms less than 24 hours, GCS 13 or less. Declining level of consciousness, such as declining Glasgow Coma IH stroke score, large hematoma defined as greater than 30 milliliters. Patient with elevated blood pressure greater than 160 millimeters of mercury, as they may need intravenous antihypertensive agents. Patients that are coagulopathic, from either medications or medical conditions, such as liver disease. Patient with hydrocephalus or at risk for hydrocephalus. Hematomas with large amounts of perilesional edema. Patients with possibility of herniation. Patients with active seizures, evidence of activity bleeding, or patients in whom the Cushing's reflex is active.
Part of the initial management will include head of the bed up 30 degrees. Goal systolic blood pressure 120 to 160 millimeters of mercury. Aim for normal volemia, normal oxygenation, normal carbon dioxide, normal glucose typically targeting the range between 80 and 180, normal body temperature, normal sodium, and normal uncorrected coagulation. Brain imaging should be repeated within 12 to 24 hours, or if there is, since the neurologic exam monitoring is very important, try to avoid or minimize the use of sedatives. Also, fluid resuscitation should be done with crystalloids, and not with albumin.
In ICH there is no indication for steroids, or prophylactic anticonvulsant, or prophylactic osmotherapy, or the use of intravenous albumin. All patients with ICH should have the ICH score documented within 6 hours of admission. These patients are also at very high risk for delirium, and delirium precautions, via the delirium order set, should be instituted early. Common IV antihypertensives are labetalol, nicardipine, enalaprilat, or hydralazine.
There are four core measures for ICH patients. 1. NPO until a swallowing screening or the swallowing evaluation has been completed and passed. 2. DVT prophylaxis. 3. Rehabilitation evaluation. And 4. Stroke and risk factor education at discharge.
ICH typically every hour. Some findings that suggest neurologic decline include Glasgow Coma score drop of 2 or more points, worsening neurologic symptoms such as an increase of 2 or more points in the NIH stroke score. New neurologic symptoms, or when one or both pupils become dilated and or unreactive. Hypertension that is becoming more difficult to control, such as requiring higher doses of medication. This should suggest that the intracranial pressure is rising and Cushing's reflex is increasing the blood pressure to try to maintain the blood flow to the brain. Also, the occurrence of seizures.
To monitor the patient with ICH effectively, you need to know the symptoms and signs the patient is on admission, the location and the side of the lesion, as well. From that knowledge, you can have an idea what other areas may be affected either by rebleeding or by edema. So asking yourself, and finding the answers to where the lesion is, say, supratentorial or infratentorial. If it is supratentorial, is it on the left side or the right side? If it is infratentorial, in addition to the side, or the cerebellum. If the lesion is supratentorial on the left, then some symptoms may be contralateral weakness, contralateral numbness, contralateral blindness, forced eye deviation or inability to cross the midline with the eyes, and aphasia. If the lesion is supratentorial on the right, expected symptoms would be contralateral weakness, numbness, blindness, forced eye deviation or inability to cross the midline, and anosognosia, or inability to recognize the deficit they are experiencing. If the lesion is in the brainstem, then symptoms and signs related to pupil function, corneal reflexes, eye misalignment including diplopia, nystagmus, difficulty coughing, drowsiness, or even difficulty with control of breathing. If the lesion is in the cerebellum, ipsilateral dysmetria, nausea, vomiting and nystagmus may be present.
We had mentioned the ICH score before. The ICH score helps predict the 30-day mortality risk in patients with spontaneous ICH. The score has 5 components: the GS, the ICH volume, the presence or absence of interventricular blood, the location, supratentorial or infratentorial, and the age of the patient. Points are assigned and the number of total points will be used to estimate the 30-day mortality risk. As you can see, 3 of the 5 elements of the ICH score are from the brain imaging, and 2 are clinical. Note how fast the mortality risk increases as the number of points increase.
To calculate the ICH volume, 3 measurements need to be done. They are measured in centimeters. Essentially, the longest diameter of the bleed itself in the axial plane, 90 degrees from that one, the second, or B, diameter, and then the C measurement or the height of the hematoma that slices in which it is visible. Knowing that every slice is half a centimeter from each other. So, for example, if from the top to the bottom of the hematoma there are 6 slices, then that is multiplied by 2 to get the number of centimeters of the C-axis. Once the 3 values are obtained, they are multiplied A by B by C, and that result is divided by 2. That is the simplified formula of the spheroid, and will generate an estimate of the volume of blood in the hematoma,
where you will also find some pertinent bibliography. Thank you.